So within the umbrella of care management, we have case management. Sometimes people get those terms interchanged. Utilization management, we have our special needs area. We now have a new area of social work because it's critical that we incorporate all facets of a member's health. We look at a holistic approach when we're talking about care management. We have a new area for health promotion and wellness. And I'm saying this because we've combined two previous units with health coaching and health education, outreach, and then I use evaluations and outcomes. We actually have a unit focusing on like research and evaluations and outcomes, but they're very critical to what we do within our department. So we have a very unique approach to care management, and we've moved into what we consider a population health approach. Historically in the past, we first developed disease management programs, and then we went to case management. But again, you cannot isolate members because they have comorbid medical conditions, they have other underlying issues, like I said, to include social work. But what we're looking at now is really focusing on a continuum of care. How can we identify people with certain diagnoses through a low level of intensity to a moderate to a very high level of intensity, which is our complex case management. In line with what we are doing for our NCQA accreditation, which is something that we're exploring this year, we chose 4 diagnoses to look at this population health approach. And these are our most chronic illnesses. So if you look at asthma, diabetes, cardiovascular disease, and COPD, it's in the literature all the time. You know, these are conditions that have a lot of utilization and tend to cost money. So we wanted to really tier them. So being a payer, we are able to collect a lot of information. This data can be claims data, can be referral data, can be utilization data. We can actually use a predictive modeling tool that was developed by Hopkins Applied Physics Lab called Adjusted Clinical Groups that gives us kind of a score as to potential future costs. So taking all of that into consideration, we were then able to tier for those diagnoses people into one of these 3 areas. And I'm going to talk to you starting at the top, but for right now I'm going to move from the bottom up. So the lowest level of intensity is just increasing awareness. There's a lot of focus on prevention. Again, education about what's going on. We can use some web-based interventions with that. Moving up to the middle level 2, which is a moderate intensity case management. We use certain tools to monitor them, which I'll talk to you in more detail. And at the very top of the pyramid is what we call our complex case management. This is provided by case managers who are either registered nurses or social works. We use a technique that we call telewatch to monitor. But the theme of this is that our outreach department, or our outreach area, transcends all 3 levels. So it's critical that they're used for all 3. So in addition to that top of the pyramid that I just showed you, because remember I said that we were focusing on 4 diagnoses within that in the pyramid approach, but we have other, obviously, areas that need to be targeted. High-risk pregnancy, members who have HIV/AIDS, people who are on dialysis, which is our end-stage renal disease program. Now, if they're pre-ESRD, then they would still be followed by a program, but not by the nurses for the dialysis program. We have members who have rehabilitative needs. So they might have had a spinal cord injury or a traumatic brain injury. They may be in a rehab facility. Maybe it's that they just suffered a severe motor vehicle accident or had severe burns. Omega Life is a different program for us. When we developed our other case management programs, we really targeted looking at how we could improve clinical outcomes, with the intent being that if we improve the clinical outcome, we improve their utilization, we try to keep them out of the hospital or the ED, and in turn, that helped decrease costs. But developing a program about terminal or end of life was quite different from us. So, obviously with this condition, you may not improve a clinical outcome, but the intent of this program is to assist them with making decisions and choices at this venture in their life. So it could be that they're assisting with advanced directives, or maybe they're talking to them about different treatment alternatives and working with the families and the providers. And then our children, these are our smaller, complex, these are under the ages of 18. So our strategies, how do we do this? So I've already talked about we have to focus on our members that have chronic, complex issues. And the other thing you do when you look at those issues is a lot of them are not able to take care of themselves. So a case manager, really helps promote self-care efforts. And they do this with a lot of coordination or collaboration between physicians. This is not a one-way street that we're on. This is a approach. So, we work closely with the providers, and we try to, in doing that, have a flow of communication and reporting with all members of the healthcare team. So it's a back and forth approach. We also often try to get information from the providers that we need, necessary information that we have to collect. And in so doing all of this, ultimately what we're about is not only improving health, but promoting satisfaction both for the member, the family, the provider. And like I said, key to this is promoting education of the members, a lot of self-management. So how do we do this? First and foremost is identifying the members. A lot of times this is where we look out to our providers. I already mentioned to you on the pyramid that we can get data to identify our members, but that takes a while and somebody has to run a report. What is most important to us is early identification. The earlier you can identify them, we can help to prevent any clinical deterioration. So this is where we really reach out to our providers, and if you have anybody that you think is in need of any of the services that we are addressing today, that you then refer to us. We try to assign our case managers geographically as much as possible so they are develop some familiarity and a rapport with the providers in that area, and also become aware of any community services so that they can help the members. We do a very comprehensive assessment, and we do this using evidence-based guidelines. And we are Hopkins. Hopkins is very into research, but I think EBP is a big term that's out today. And I say that when we develop our outcomes, we do that based on, if it's a diabetic, on the American Diabetes Guidelines, or the GOLD guidelines for asthma or our COPD patients. But the assessment is comprehensive, and we get this information not only from the member, but from family members, from the provider, any members of the healthcare team, because until we can identify what the needs are, whether it's medical, psychosocial, cultural, it's hard for us to develop this treatment plan that comes next in terms of how we address our members. And there's a lot of intense outpatient follow-up that can be done in several different ways, face-to-face, on the phone, etc. And once that plan is developed, there's a lot of monitoring to assure that they are continuing on the path. So, part of this also is not us developing the plan, but having the member develop a self-management plan, because if we have one goal, and I'm sure, providers can relate to this, you have a goal that you want your member to achieve. But often that's not the most important thing for the member at that time, and then always evaluating what we're doing in terms of moving forward. So again, how do we do this? Now, I'm at the top of the pyramid now, because this is my area, and I'm going to now come down. These are the ones at the top. These are the most intense members. They have the most immediate needs, their most intense, complex needs. So with the case managers, whether they're the nurses or the social work, they work one-on-one on them. I already talked about the different assessments that we have to do. And these are not necessarily just because they're requirements, but it's understanding the big picture of the member and how we contact them. So we've gotten very innovative. It used to be we tried to do both some telephonic and some home visits, and we still try to do this as much as possible, but again, sometimes we have limitations because of geographic areas. And the reason why I say we try to do the home visits, because you get an entirely different picture when you visit somebody in the home versus what you hear on the telephone. If you're assessing a diabetic member and you're trying to find out, you do a 24-hour dietary recall and you're trying to find out what it is that they eat, they tell you one thing. We found a lot of times, sometimes they tell you what they think you want to hear, but then you go into their home, and if you happen to look in their cupboard or their refrigerator and they live by themselves, nothing that they said they ate is in there. You get a whole entirely different story. Same way with an asthma patient. You can get in there and you can see different triggers, pets, insects, carpet, rugs, things that trigger events that you may not see unless you go to a home visit. And because phone calls, particularly with the Medicaid population, is often difficult. They're a mobile population. They move. Oftentimes they don't keep up with changing their information. It's sometimes hard for us to reach them. We have explored using emails with all of our members. We find that works very well with EHP and with USFHP, and sometimes even with the Medicaid population. And like I said, all of this builds into a care plan with a mutually agreed upon goal. And we like to share this plan with the providers as much as possible, because like I said, we're not going down a different path from you. We're trying to do this in tandem with you.